it's those interactions surely that we should be searching for. So I'd like to suggest that the Rothman necessary sufficient causation model allows an interesting dimension into genomic epidemiology. So first of all, it's very explicitly looking at interactions as the basis of multifactorial causation. It's also, to use some jargon words, provides us with a framework in which we can deal with phenocopies, in other words, diseases that look about the same, endophenotypes, which is a disease which is split down into different subgroups. And it also allows us to see the beginning of the end, because we start to build up a picture of what's important. So I would suggest that we do need to think about genomics not just in its own right, not just in terms of individual risk, but in terms of population risk. And what I've suggested is that rather than thinking about it as the end of the beginning or the beginning of the end, perhaps we should think about it as, well, the end of the beginning is a G and the beginning of the end is an E. So it's genes and environment together which is the key. The focus of this session is new technologies, and new technologies have lots to deliver, but you need to treat them with respect. And if there's one tip that I can give you, when you board a bus in Malta, for goodness sake, make sure that you can see both the beginning and the end. Thank you.
Thank you, Professor Strachan, and thank you for having added some Maltese flavor to your presentation. I'm sure the Malta Tourism Authority would have been very pleased to see this presentation. And we now pass to ask Professor Ekdahl to deliver his keynote presentation, asking the question, what are the smart drivers of infectious diseases?
Good afternoon. I'm happy that despite the late hours that we have so many in the audience. First, allow me to thank the organizers of this conference for their kind invitation, and I'm quite honored to present here to you what are the smart drivers of infectious diseases. There is an expression that says hindsight is 20/20 vision, and I think that perfectly describes much of the discussions we have indeed in public health. After an event, everyone knows everything, and you have a lot of people that have very firm views of what should have done at different stages. But the grim reality is that during a public health event, we do often not know really what is around the corner. So if you look at SARS, HIV, or the Nipah virus, and recall some of the initial reactions, then I'm sure that you know what I mean. So the reality is that we cannot prepare for what is completely unknown, but there are issues that we can do. We can anticipate the coming of the next influenza season. We can make evidence-based assessments on how rapidly antimicrobial resistance will develop, and this is an area that a lot of people are engaged in right now. We can take steps against irrational opposition to vaccinations. There have been several seminars on that one, and we could take a very firm stand against hospital-acquired infections. But one of our best bets when it comes to infectious diseases is that we should be looking very, very closely at the infectious disease drivers. Some time ago, ECDC did a foresight project that described the socio-ecological changes in the EU and how these changes might influence the control of infectious diseases in the mid-term perspective by 2020. The project identified 3 macro-level drivers that are essential for understanding the emergence of infectious diseases in Europe. The first one is globalization and environmental change. The next one is social and demographic drivers, and the third are the public health system drivers. And of course, within these broad categories, there are sub-drivers where we could put even more attention to. Let me first talk about the climate change drivers, as this would fit very well in this session. I don't think any one of you are unaware of the grim realities that climate change now appears to be approaching or even exceeding the upper boundaries of the projections of the Intergovernmental Panel on Climate Change, IPCC. Over the past centuries, ecosystem decline, loss of biodiversity, stratospheric ozone depletion, and climate change are some of the environmental changes that we have experienced. And climate change is indeed extremely tangible. The worldwide mean surface temperature has increased by 0.74% over the past 100 years. The world sea level has risen by 1.8 millimeter per year since 1961, and the Arctic sea ice is retreating by 2.7% per decade. But this is now rapidly increasing, and I think you have all seen the horror pictures from this summer with the Arctic ice melting down in front of our eyes, literally. So the sea surface temperature are warming, mountain glaciers are shrinking, oceans are becoming more acidic, extreme weather events, as was recently seen in New York, are increasing in frequency and intensity. And these climate changes have already had noticeable effect on communicable diseases. This is a map of my own country, Sweden, and it shows the distribution and the relationship between climate variation and tick-borne incidence over the past decade, and some projected changes, showing that Lyme borreliosis is now entering into areas where it was not seen in the past and is becoming more frequent. Another driver is travel and tourism. This is the second driver I would like to talk about. And if we are looking ahead to 2020, it's projected that by that year, nearly 1.6 billion international flight arrivals worldwide will take place. And meanwhile, global trade has increased substantially, creating so many opportunities for the spread of disease pathogens, vectors, reservoirs, really saying that the old cliche that infectious diseases respect no borders. What may be interesting to see in this slide is also, if you note that in 2 years, in 2003 and 2009, there was indeed no increase in the number of flights. And that coincided with the SARS epidemic in 2003 and in the beginning of the flu H1N1 pandemic in 2009, showing also that when we do have these large outbreaks of infectious diseases, they have also an immense effect on global trade, on global travel, and not least, a huge economic impact. This map shows the dark green, the distribution of the Asian tiger mosquito, the Aedes albopictus. And that mosquito is quite important and a nasty one. It's the main vector for important viral diseases, including West Nile virus, yellow fever virus, St. Louis encephalitis, dengue fever, and chikungunya fever. And this mosquito was imported in Italy in the 1990s, and the climatic conditions are favorable, so it spread quite rapidly. So within a decade plus, this mosquito has spread in large parts of Italy and also some other parts of the Mediterranean. What happened then is that with a vector present, we saw in 2007 an outbreak of chikungunya fever, and in 2010, France experienced local transmission of dengue fever, a disease that we normally only see in the tropics. The third driver I would like to talk about is social inequality and health inequalities. We know very, very well that health improves according to the socioeconomic position of the people and of the communities. And I may be simplifying it a bit when I'm saying that this hospitalized child would have had a better chance to stay healthy had her family been wealthier. But there is an undeniable correlation between health and wealth. And vulnerable groups suffer disproportionately to infectious diseases in each member state. In ECDC, we have recently been, for the last 2 years, been working with Roma population. This is an underserved population, and if you are going from one country to another, the life expectancy in this group is around 10 years lower than in the rest of the population. A huge failure of public health in Europe. And we know very, very well that countries with higher wealth and lower income inequalities have lower incidence of diseases such as tuberculosis. This graph shows the distribution of tuberculosis prevalence rate for each EU member state, and it's plotted against something called public wealth index, which measure the income distribution. And this metric takes into account the relative high level of wealth in Europe, but also controlling for its distribution. And it's very clear from this graph that the wealthier the country is, the less TB incidence. But it also shows that as countries rank higher on the public wealth index, the proportion of TB cases that are foreign-born generally increases. So with increasing index, the TB rates dropped, but the proportion of foreign-born TB cases increases. SARS in 2003, caused by a novel coronavirus, other epidemics have shown us how much Europe has needed a good early warning system for new and emerging diseases. So with a European surveillance system, TESI, and the early warning and response system, the EWRS, ECDC has established a two-way approach to disease surveillance and monitoring. So what we are not capturing in the annual reporting in the traditional surveillance system, we are picking up through EWRS in what we are calling epidemic intelligence, mainly cases and events reported by the countries. And this is a system, this dual system has proved very effective, not least during the influenza pandemic in 2009. And it ensured a real-time dissemination of this emerging health threat. And we have capacity to very quickly install daily reporting of cases. That was also done during the E. coli outbreak in Germany recently. ECDC's mission is to identify, assess, and communicate current and emerging threats to human health posed by infectious diseases. So our mandate is strictly within communicable diseases and not the non-communicable chronic diseases. And we act as a risk assessor. We have a clear role in risk assessment, while everything concerning risk management is done by the European Commission and by the countries. But we do help to coordinate the EU countries when it comes to preparedness and response capacities. So in a way, we act as a hub for different networks of experts across the EU, where our relative small size, 350 people in Stockholm, is heavily reliant on the good capacity in the member states. The role of ECDC is to facilitate this coordination of communicable disease control and prevention among the EU EA countries. So we are working not only with the EU 27, but also with the 3 remaining EA countries, Norway, Iceland, and Liechtenstein. And we are working very, very closely with the European Commission, who is the one that is coordinating with the health decision makers in the member states. So to sum up, let's go back to the initial picture of a bulldozer and the drivers. So if allow me to use that metaphor once again. Could we really say in what direction this bulldozer is driving? I think realistically that it will be difficult to predict the actual timing of health events, but with proper surveillance of the drivers, and not only of the disease trends, we will at least be able to predict the overall direction of new emerging, re-emerging diseases. But here in yellow is